Well, welcome everyone to our Friday morning sign out with the professor. I'm very pleased this morning to have a returning guest, our wonderful colleague and friend, Dr. Jong-Sing Yu, who's Associate Professor of Pathology and Director of Pediatric Pathology here at the University of Oklahoma. And she's going to share with us some insights into pediatric renal tumors, which is certainly a very appropriate topic and a challenging area for general pathologists and perhaps also for pediatric pathologists as well. So Jong-Sing, please take the floor and we will move forward.
Thank you very much, Dr. Hassel, for your introduction. Yeah, we're going to concentrate some kidney tumors this morning. You know, the kidney tumor, you have to see some growth, know some, especially pediatric tumors. You have to know a little bit of clinical history. The age difference, like a congenital, 1 year, 2 year, 15 year, they all make a difference for your differential diagnosis. So pay attention to, and whenever you do the deal with pediatric kidney tumors. So this one, the first one I'm going to show you is a 4 days old male infant with a kidney tumor. And the patient also had hypertension, was treated. So grossly, you can see this tumor, that's a residual kidney. And the tumor kind of yellow, tan, kind of like a more fibrotic appearance. And with normal kidney, there's looks like a demarcation, but on the microscope, I will show you. Right now, you can see seems like a demarcated, but seems no capsule. So for pediatric tumor, capsule, non-capsule is important for the diagnosis differentials. So usually I will tell our resident to pay attention to those capsule or not. For this one, we do not see capsule. There's demarcation, but seems not very well separated. Now I'm going to this case. So this is a low power view. So this is a renal capsule. Renal capsule. This is a residual normal kidney. This is a tumor. You can see at the microscopic level, the normal kidney and tumor kind of on the edge. There's no good demarcation. Actually, the tumor cells, normal kidney kind of intermingled on the edge. So keep moving for you so you can see more. So that's like a finger-like normal kidney. And this is a tumor. Continue. So when you see this kind of pattern, you make something, could be which kind of tumor. This is a feature of this tumor. So no non-encapsulated. And there's you know, interface kind of like intermingled. So that's the normal kidney, and this is the tumor. So keep moving around. You can see sometimes, not always, you can see those like a bluish nodule. And close look at those bluish nodule. They are cartilage. So that's also sometimes we can see. And then we go close look at the tumor. So move inside the tumor. I'm going to move slowly and just focus here. Okay. That's the main body of the tumor. Kind of pale pink. And this part, you can see the tumor kind of nuclear, kind of spindled. More looks like nuclear, that's pink area. Pink area looks like a collagen. Higher. That's more for nuclear details. So bulk of the tumor is spindle cells with like a pink fibrous collagen. And you move around, the tumor cells kind of like a, in I'm right now evaluating the tumor, I will call it like a very bland and not much pleomorphism. And Let's move around. Scattered mitosis. Like this. No necrosis, the cellularity is not very high. And the spindle cell have some collagen. Yeah, looks like a few days old baby. And with that, just normal kidney and tumor intermingle on the edge. So the diagnosis, probably most of you already get it. This is mesoblastic nephroma. Mesonephrotic adenoma, nephroma is kind of spindle cell proliferation. And there again, the scattered mitosis, but cellular morphology is kind of bland. So mesonephrotic, mesoblastic nephroma. And there are two variants. One is a classic variant, one is a cellular area variant. So this one is not very cellular, so we call it a classic variant. So all the features here, usually they are present in the newborn, congenital, but not always. Sometimes a little bit older patient, like 1 year old, but never over 3 year old. Majority, I think 90% is present in the with 1 month to 3 months. So that's mesoblastic nephroma. And sometimes you can see this kind of extramedullary hematopoiesis. This is also common. This is an extramedullary hematopoiesis. So that's all over the tumor. Just show you the overall. All right. For comparison, I show you a second case. This one is mesoblastic nephroma classic type. The number 2 is 1 month old and left renal mass, discovered on routine well baby check. This cross-section of the tumor. So compared to last one, this one kind of more like a flashy little bit, more soft. There's necrosis hemorrhage here. The tumor, this one is a little bigger, 9 by 4.8 by 4 centimeter. So again, there's no, almost the kidney replaced by this tumor, hardly to see any capsule, but also because like almost entirely replaced, difficult to tell the capsule or not. So let's see microscopic. This is the second case. So when we look at the low power, that's renal capsule, that's normal kidney. So move around. So is this normal kidney? Here. So here's the tumor. This normal kidney. So this tumor and normal kidney kind of more well circumscribed, more demarcated from the normal kidney. There are few like a normal glomeruli. Usually, occasionally you can see a few glomeruli or normal tubules go into the tumor, but usually not like a last case, go into a distance. And also this tumor do not have a capsule. So that's a close look. The interface. So tumor, normal kidney, and kind of sharp demarcation. We go around, maybe a little bit entrapped tubule like here. The usual not like a very deep distance. A few entrapped tubule like this, normal tubule. So then you go to like a look at the bulk of the tumor. So from a low power, you can see probably you can get the feeling the cellularity is higher than previous one. Again, spindle cells. There are some nuclear overlap. And look at the mitosis. It was slightly more than last one. Get the feeling? So mitosis, 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 mitosis. So seems mitosis compared to the last one increased. Here's more clear locale. It's 40x already. So that's morphology. But the overall cell morphology kind of still like a blend. It's not very clear, very highly pleomorphic. So that's the cellular spindle cells in the very young child, like a 1 month old. So probably you already have in your mind the diagnosis. Mesoblastic nephroma cellular, should remove this cellular type. So it's cellular type, this one. I think probably 70% cellular type associated with NTRK3 rearrangement, ETV6 NTRK3 rearrangement. So if you have the, if you can do it, better do it to confirm it. So in general, prognosis in general is no difference cellular type, classic type, but the recurrent rate, cellular type slightly higher than classic type. But overall prognosis depends on stage. So the treatment is resection, usually do not need chemotherapy. So make a correct diagnosis is important. And also for cellular variant, follow up more closely because they have increased recurrent rate. So that's 2 cases, like a very young patient. Any question for these 2 cases?
That's not so far. They may. I've told them they can type their questions in if they'd like. And
okay, no question. I will move on. Anytime you ask question, okay? So that's almost congenital, very young. Those tumors should not happen after 3 years. So the 3rd case, also young patient, 3-year-old boy with a recent history of hematuria. So this is the tumor. So that's a residual kidney, the tumor kind of more usually look at central line or in the medulla area. So very circumscribed, very well circumscribed. So that's another cut section. So very well circumscribed. This, to the kidney is very separated, but there's in the lower pole involvement, Okay. 3-year-old. Let's see if I have normal kidney. Okay, that's normal kidney capsule. That looks like a hilar area, a big vessel here. Big vessel, some fat, so that's a renal sinus area. That's normal kidney. Then here's tumor. So this tumor seems to have partial encapsulated. That's pink, partially encapsulated. And that's the tumor. So we go into the tumor. So, and the low power. You can appreciate something like this area. Maybe there's some. So this articular vessels So that's kind of very catch your eye, the vessels, vasculature. There's another one. Close look. So the vessels kind of what we call the chicken wire. So like a branch vessel, very prominent. So architecture-wise, you notice this vessel, so many vessels. Then you look at the cells, tumor cells. Kind of like a pale, and some of vacuoles looks like, or clearing looking. A cuboidal nuclei, round nuclei, with some like a very clearing cytoplasm. And this is the vessel. Most time around the vessel, the cells kind of more spindly, away from vessels kind of clearing. Looking. So this clearing usually see in probably 30 to 40% of tumors. The cells does not look like a or adult type of clear cell renal cell carcinoma, but this entity is clear cell sarcoma of kidney. So it's unique to the pediatric population. But you can see the cells are clearing, and the vessel is another feature. There are some other morphology variant, but at least you should have like at least focally have this clear cell area. Go over the whole tumor. There is some degeneration. Let's do that area. That appears vessel part more. Appreciate the vessel is getting better. So the vasculature, just like if you do mixed liposarcoma, they call chicken wire vessels. This is also in this kidney tumor called the clear cell sarcoma of kidney. So it's another feature. Immunohistochemistry in the past usually do not help much. But nowadays, we know this tumor associated with BCOR mutation. So if you do BCOR immunohistochemical stain, going to be strongly positive. There are few other genes involved, but the BCOR immunostain is a very helpful feature for that. Let's see. So this one diagnosis is clear cell sarcoma of kidney. We call sarcoma because they are negative for cytokeratin. It's not epithelial tumor, so it's sarcomatous tumor. About 70 to 40% with bone metastasis. So in the past, people also call this tumor as the bone metastatic renal tumor of childhood. Compared to Wilm tumor bone metastasis usually less than 2%. So this one is very high rate of metastasis. So if you think of like a young child, infant, you have bone metastatic tumor, you have this morphology, the diagnosis of clear cell sarcoma of kidney. So I want to see about this. BCOR mutation, and another one is YWHAE and the NUTM2 fusion, that's a gene change. Majority, I think they said if you do BCOR immunostain 100%, should be diffuse strong positive. It's a very useful marker. This is a malignant tumor, need to treat. So recognize this one is very important because they need a chemotherapy. Any question about this one?
So Jung-Sin, that YWHAE mute fusion gene is also seen in some uterine sarcomas in adult women. So that's kind of an interesting correlate there.
Yeah, yeah, exactly. Some recurrent tumors, recurrent genetic mutation can see in different tumors. For instance, the second tumor, cellular type mesoblastic nephroma, that translocation is the same as the infantile fibrosarcoma. So that the infantile fibrous sarcoma usually in the soft tissue, represents the kidney. They are morphology kind of like similar. So some tumor is really morphology driven by those genes.
Yeah.
Interesting. I think as more we know those genetic changes, so we probably, all the tumors should subclassified by the genetic change. Okay. And we go to number 4. Number 4 is a 4-year-old male with history of renal transplant 8 years ago for FSGS. So a renal mass identified the native kidney during it's incidental finding during workup of a transplant kidney. So this one is in the native kidney. So when they do renal transplant, they usually keep the native kidney inside. So this is the resection. That's a residual kidney a little bit. There's fat. So you can see the kidney is very atrophic change. And this surrounding fat. So this is a tumor, very well circumscribed. Looks like have a capsule. And tumor size 4.5 by 4 by 2.5. It's very yellow, looks like a firm yellow. So this is the tumor. So that's the normal kidney, residual kidney on the right. That's the tumor here. At the low power, you can see it looks like a papillary a little bit, like here. With the CT change. We find the better area, we can stop. Now we'll stop back here. So it's a tumor arranged in the cord. Some looks like the papillary structure. This is my collection. It was faded, this slide. Let me just show you the morphology. So the cells consist like a columnar cells. Have a prominent nuclei and a large nuclei with sometimes looks like prominent nucleoli. Nucleoli. And there's we call voluminous cytoplasm, a lot of cytoplasm. And usually when you look at the lower power, the tumor looks very pale because so much cytoplasm. The cytoplasm are usually pink to clearing. So this tumor, when we do immunostaining, I remember it's cytokeratin negative, CK7 negative. But a few other like melanocytic marker, HMB45, focally positive. So with this history, with this morphology, you know, voluminous cytoplasm, prominent nucleoli. So we did the TFE3 gene mutation. It is a positive for TFE3 gene mutation. So the diagnosis is renal cell carcinoma with XP11.2 translocation or TFE3 mutation in a transplant patient. I like to show you this case. The one thing, this morphology classic, usually like a pink cell morphology, voluminous cytoplasm, papillary structure. Another thing is in transplant patient. This tumor had to be reported associated with cytotoxic chemotherapy. So in this patient had a renal transplant, received some chemotherapy. Other times you have a tumor, patient have a tumor like a leukemia, some other tumors get a treatment. Also later on developed film tumor, develop this tumor. So there's association with that. So if you get young patient get a looks like a secondary malignancy in the kidney, and with this morphology, think about this tumor to make sure do TFE3 rearrangement, gene rearrangement test. Some of these tumors, majority relate to the TFE3 gene mutation. A few subtype can be associated with TFEB mutation. So you can, if TFE3, you really think that this tumor TFE3 negative, you should do TFEB mutation test. So we talk about this one. That give you another. This is the classic morphology. Give you another case. 11-year-old girl with 3 months history of increased neck mass. They give initial distal infection, give antibiotics, but did not become better. So the patient also had weight loss, fatigue, lump on the head. So they did a neck lymph node biopsy. By radiology, this patient is said have a large mass essentially encircling and partially infiltrating the kidney. So initially they think the tumor is perirenal, so encircling kidney and extending into the retroperitoneum. And there's a liver metastasis, the scalp neck metastasis, lung metastasis. 11-year-old, a little bit older, but still clinically consideration, they think neuroblastoma, because that's usually in children and the metastasis early. So they did neck lymph node biopsy. So this is the biopsy specimen. The lymph nodes already gone, that's a deeper section. But this is a biopsy, majority biopsy area for the tumor. So low power, you can see, looks like a papillary, looks pink. Again, looks kind of almost a papillary structure. Here, looks like a papillary structure. And the papillary looks like a pseudo papillary. So I think the papillary generated by the discohesion of the cells. So this group just, separated because discohesion and form this pseudo papillary. The cells not very pleomorphic. So when we put the slide, look at the slide, immediately think about if this could be like a solid pseudo papillary neoplasm of the pancreas. The morphology looks really classic. But that tumor is kind of like a benign tumor, so not a metastatic to all the places. Regarding the clinical consideration of neuroblastoma, this is not neuroblastoma, of course. Neuroblastoma is small blue cell tumor. This is not. This looks epithelial tumor. So this tumor we did run a few immunos. So because we think about could be like a solid pseudopapillary neoplasm of pancreas, although clinical presentation does not look like that. So we did a beta catenin, it was negative. And this one is not like a classic voluminous cytoplasm, but because there's a kidney mass there, so we made some differentials that time. So if pediatric renal cell carcinoma could be like a papillary renal cell carcinoma, although this is a pseudo-papilli. Renal cell carcinoma is a real papilli. It's not like this can generated by separation. So less likely, we also did a CK7, it was negative. So make the papillary carcinoma less likely. And because on the young patient, so we think of could be TFE3 XP translocation tumor. So we did a TFE3, it was positive. So this diagnosis confirmed by this one. We run a few immunos. The tumor positive for PAX8, so indicate this come from kidney. And also AMCAR positive, usual characteristic for a translocation tumor. CD10 also positive, characteristic for this tumor. Negative for CD7, CK7 should be, CK7, so rule out the possibility of a papillary renal cell carcinoma. Because the neck lymph node, we think this could be papillary structure, could be like thyroid carcinoma. So we talk to clinicians. They say, no, the thyroid looks good. But anyway, we did TTF1, thyroglobulin, they are negative. So beta catenin for that tumor, for the pancreatic tumor. So final diagnosis is have TFE3 rearrangement. We call the metastatic tumor with the feature of consistent MIT family translocation renal cell carcinoma. So classic feature in the kidney help, sometimes difficult, like metastasis, especially the radiologists suggest the tumor is more like outside, not inside, probably still inside. But I did not have follow up the patient after treatment. I don't think we had the renal resection or not, or lost the follow up. I don't remember this case. But so just think about those kind of tumor can have unusual morphology. You just think about putting the differential, do some immunos, remember TFE3 or TFEB rearrangement test is helpful. So any question on this tumor? So this is another translocation tumor, but morphology is different. All right. Let's continue. This one is a 14-year-old female with a history of multiple angiofibromas of the face. I have a renal mass. So history is important. This is a tumor. So this kidney, residual kidney, this large tumor, flashy, yellowish, lots of hemorrhage. Let me show you. Here, the hemorrhage. Jump to your eye. Lots of hemorrhage. Look, so that's a little residual kidney here. That's a little residual kidney. That's the tumor. So let's look at the cellular morphology. We can see like a sheath of those large polygonal cells, individual cells, with a sharp cytoplasmic membrane. And prominent nucleoli. You see this here? We call cherry red nucleoli. And clear cytoplasmic membrane. Kind of looks carcinoma looking. So if this carcinoma, but that one looks like our classic clear cell carcinoma of the kidney. So we look around because clear cell carcinoma of kidney usually is translocation type in the pediatric population. This one seems not like a papillary, not like the case we saw previously, the two cases. But it's lots of hemorrhage. Then you look around, there's lots of pigment. Indicate actually some calcification here. Then you move around, you can find something here. So you can see some adipose tissue, fat. Okay, you think about something now because the clinical history have multiple facial fibro angiofibromas. So that make you think about, I want to look in something more. So looking vessels now. Sometimes it's easy to find oh, this is a vessel. This is a relatively large vessel. And a close look. This is the endothelium. This muscle layer support because a very large caliber vessel should have smooth muscle. However, to smooth muscle or something cell peri those endothelial cell and transform to these vessels. So these tumors. So these tumor cells actually is come from this wall of the vessel. We look around. So, and there's few other areas also like this. So this is, you have an angio component. This one also not a very myo looking, but this transformed myo parasites, like smooth muscle transformed cells. Angio, myo, then you have fat lipoma. This variant is a epithelial variant. It's very epithelial cells with cherry red nucleoli. So that's the thing. So clinical hint is multiple facial angiofibroma. That is a feature for suggest tuberous sclerosis. So this tumor, you know, we call the AML, angiomyolipoma, is closely majority also associated with tuberous sclerosis. Also, but of course, you can have those like non-syndrome related, but the majority of time is related to some syndrome, tuberous sclerosis. So remember, clinical history give you some hint. Then you see some. If you look at the fat first, then probably you get it already. You find this fat, and you see those vessels. So that's the epithelioid variant. Last week, for this tumor, you want to do immuno. This tumor is because like a kind of pericytoma kind of a tumor, like a pecoma-ish tumor. So if you do HNB45 or myelin A, they usually positive. So this is the HNB45 did on this case. So the brown is positive. You can see the tumor cells, strong positive. HNB45. S100 usually negative. SOX10 I did on the recent case also negative. But HNB45 should help you make a diagnosis. Epithelial variant. So if the epithelial variant, there are classic variant. So last week, I think, or week before, we had another case. I'm gonna share with you. So this one is epithelioid angiomyolipoma. Vessel, myo, and lipoma. So next one is a recent case, 14-year-old, previously healthy female, present with a new onset of seizure. So seizure give you some hint. Have a renal mass biopsy. They did a core biopsy, just want to confirm. Majority of the time, radiology very helpful. If you have a tuberous sclerosis, you suspect for this tumor, when they do radiology, they can find fat component. So it suggests of this diagnosis. But right now, the tumor, although clinical suspicious, but when they do radiology, said not much fat. So that one they did like a core biopsy, needle core biopsy. So this needle core. So close look. They are spindle cells. On the biopsy, we did not see much fat. But this is a good vessel. So that's the endothelium, the lumen, thick wall vessel, and smooth muscle transform to the tumor, spindle cell tumor here. So when we receive the biopsy this time, there another vessel. So it's very closely associated with big wall vessel. So at that time, we get the diagnosis, clinical workup, patient, the brain tumor is the diagnosis of the, I don't remember exact diagnosis, but anyway, clinical now is called the tuberous sclerosis. So with that information, with this morphology, spindle cells, with angio component, so we did the HMB45, it is positive. So confirm this angiomyolipoma is a classic variant, we call it. So very focal, you may get some sense, probably there's a fat content, but sometimes, you know, if it's the resection, of course, you will find some fat. Also, but this one is like a adipose tissue poor, but you have that. So HMB45 immunostance help and clinical history help because the patient do have tuberous sclerosis. This one is a classic type. So classic type usually considering benign. Epithelial variant sometimes people argue it's more like a malignant behavior, but there are some criteria to call it malignant or not. So I will not go detail with this. I think WHO book have all those criteria. Yeah. In which situation you will call the epithelial variant like malignant or not. But classic type usually is benign.
So, Jong-Seen, real quick question. Do the radiologists ever just make that diagnosis based on MRI features or things like that so that they don't have to biopsy those?
Most times they don't need a biopsy. If they have a classical feature, have fat, have vessels, they think with clinical history, tuberous sclerosis, most times they just watch.
Yeah. The
only biopsy is like a not sure one. But AML also kind of, you know, in the category of picoma. So sometimes can be multifocal. They worry about like you have a mass in the kidney. They think probably AML, angiomyolipoma, and you have another mass in the liver. They say it is metastasis. So in this situation, they will biopsy to make sure it is the right diagnosis.
Yeah.
So yeah. If only have kidney tumor, radiology classic, and they usually do not biopsy. I have this case in my study set. It's a very classic type of AML. So it's resection, tumor resection, not partial nephrectomy specimen. So you can see on the low power, you will see fat and vessel, angio, this one is more spindle cells. That's the myo part. Myo part, angiomyolipoma, this classic type. Sometimes they have like compression to other area, they do partial nephrectomy. I think this one. And let's go the last one. Last one, I probably won't give you the history. I give you the histology first. So this one made us diagnosis easy because of clinical history. But before that, let me tell you, this is a 13-year-old boy with what history is? Let me see. This one, last one, patient. 13-year-old boy with a polycythemia, have a hematuria, so follow up by benign clinical in the renal clinical, nephrology followed up. Then later on did a genetic test, and then they find multiple renal mass. So renal, like a cystic mass, very small. So they watched for a while. Then later on they decided there's needed to resection, so they did a resection. I'm gonna show you this tumor, this one. Lower palmar. So that the kidney, that's one cyst. So those kind of small cysts, they followed for a while. Now they have a grow into the mass. But that's cyst. Those kind of cysts, they followed. Those kind of cysts are kind of bilateral, slowly growing. Tumors. That's a cyst of 12 of the tumors in this slide. So this is the tumor. Some small cystic dilatation inside tumor, but largely is solid. So that's a demarcation from a kidney. That's the cystic area. So let's go higher power look at. So this is the cystic area. It's one small, looks like a papilla looking. The cells are large, prominently looking outline, also kind of voluminous. The cells pink, cytoplasm very pink. So cherry red nuclei. So you would think about initially, oh, this could be translocation tumor, but to tell you this is not. Pink cytoplasma, kind of they call the oncocytic change. So that's a tumor. The tumor positive for cytokeratin is fine. And those cyst lining, the cystic area, they follow up, I think have like a similar morphology. That's a cyst. Also lined by similar type of cells. That's the cyst lining. So now we go back to the history, this one. Because the polycythemia, they did a genetic workup. They found the patient had the fumarate hydratase mutation. So then they did this finding kidney tumor. Follow up, this is the tumor and multiple cysts. This is our tumor, this one here. Then others like multiple small cysts. So you see the histology already. So this tumor, when we do immuno, is positive for pancytokeratin, I remember, and also for the GLUT1, because this one related to a stress factor, so it's positive for that. More importantly, the cyst also positive for GLUT1. So we did fumarate hydratase staining. So this is a normal kidney, this is the tumor. You can tell normal kidney have preserved those staining, and here tumor get a loss of this staining. So it's a very helpful marker for that. So the diagnosis is fumarate hydratase deficiency RCC. This patient had a multifocal. Sometimes if you do not the gene mutation, you saw those like oncocytic change, and some patient have a cutaneous or uterine leiomyomatosis. So people may call it hereditary leiomyomatosis and renal cell carcinoma syndrome. And our patients do not have like a leiomyoma, only have this renal tumor. So also did the multiple cysts have a similar morphology, just not expansor growth. So we think it's incipient neoplasm. So for this case, the patients, I think after this tumor, this nephrectomy, they follow up another kidney for the cyst. And the patient, I think prognosis is good. So far, it's not having another kidney is still preserved. In general, for fumarate hydratase deficiency RCC, they usually present in the late stage, wide metastasis. They said, prognosis is very aggressive, prognosis is bad. our patients are unique because we find it early, so the prognosis is not that bad. So that's the case we learned backward. But if not, if you get the tumor like oncocytic, and if especially patient have leiomyoma in other part, think about this tumor. Do this fumarate dehydratase immunostance will help for your diagnosis.
So, Jung-Seen, the leiomyomas that these patients have are usually often confused with leiomyomatosis or leiomyomas with bizarre nuclei, so they look quite atypical. But those were usually presenting in, adult middle-aged women rather than the pediatric age group in this situation. Are the renal tumors more typical of the pediatric age or more commonly seen in adults?
Still more commonly seen in adult.
Okay.
So this case is unusual because they already know the mutation. And because the mutation is a germline mutation. Yeah, in adult, they are sometimes germline mutation, sometimes somatic mutation.
Uh-huh.
I would
think so there was some family history here then?
This one do not have a family history. I think they did, I think the patient is the first patient in the family.
Okay.
With this mutation. Of course, this in diagnosis analysis is important because if you see this, you have to recommend them to do germline mutation test.
Yeah.
Yeah, it was in adult. That's the only case I see in pediatrics. So I thought that probably interesting.
Yeah, fascinating case. Questions from some of the other participants today? Anything people want to chime in on or ask a question further about? Well, Jung-Seen, this has been really a fascinating session. I appreciate your time and preparation, and I'll just comment to the participants here that we were not able to scan these slides in advance, but as soon as our scanner is repaired and back up, we will get them scanned and link them to the recording of this session so that you can come back and review them, because we realize that's a very helpful feature of this effort to go back and review after the session. Any final comments, Jung-Seen?
No, just think about pediatric renal tumors, think about syndromes, genes, is going to help for your diagnosis.
Yeah. Well, thanks so much, Jung-Seen, for your time and effort, and thanks everyone for joining us. I'll just mention that next month we also have a guest professor, which will be Dr. Kyle Wright from our Division of Hematopathology. Also a return engagement. His first session was extraordinarily well received, and so look forward to that.
Thank you. Have a nice day.